Okay, so today I'd like to focus on a case study, which is the new definition of pain in that was proposed and established in around 2020, and then finally in 2021. And I would like to show you that this is a case of not just conventional definition that scientists of pain proposed, and not just a completely evidence-based update of the consensus on pain, but rather, to me, it's a case of conceptual choice, meaning there was a choice of the best conceptual tool that would serve the ends and the objectives of the community that studies pain. So what I would like to do in this talk is firstly to say something about why definitions matter in medicine and elsewhere, but in medicine this time. And then I will focus on the IASP definition of pain and all the difficulties that arise concerning that definition. IASP is the International Association for the Study of Pain. And then I would say that prima facie, it is obviously good, and maybe also at second thought, it is a good definition. It is a good conceptual choice, but also it has a price to pay. So there was a conceptual trade-off to a balance between pros and cons to make. And that's why I called it a conceptual choice. So in the end, I would suggest this is definitely a role for philosophers, is a kind of task that should have the input of people like us. Sometimes it is the case that philosophers work together with the medical community in order to refine concepts and to choose concepts. And this is one of the cases where this collaboration actually took place, but it's not normal. I mean, it's more frequent that philosophers are not part of the project, which is, I think, let's say, a missing opportunity for both communities. So why definitions matter in medicine? Sorry for the sort of disquieting photo I chose. Definitions shape what is measured, and then what is treated, and also what is reimbursed in healthcare systems where disease codes matter. Definitions are of medical concepts often are operationalized in scales, in measurement scales. So the way we define something is immediately translated into how it is measured. And then, so data come from data change according to what definition we have in the first place. So they're not just linguistic labels, they function as operational tools. We do something with concepts and definitions. So I'm using the word concept and definition as it were synonymous, but I know that it's not always the case that concepts have the form of definitions. But in fact, most concepts that we use in everyday in our psychology, I mean, the cognitive notion of concept is usually not synonymous with definition, because we use concepts as prototypes, concepts as exemplars, concepts as theories. Yes, that's an important clarification to make, but it is still true that when in science, scientific communities, or for research purposes, concepts are made explicit. they take the form of definitions or a list of conditions or criteria. So that is to say, I know that in real life, concepts are seldom definitions, rarely definitions, but in research practice and also in healthcare documents and proceedings and guidelines, concepts do take the form of definitions quite often. So how are these definitions proposed, made, and changed? Well, of course, they reflect epistemic, they reflect the evidence, they come from the evidence, but also I think we should not forget the fact that they also reflect practical and ethical priorities. And I did some of these work with concepts of health and well-being in previous work. So what is conceptual choice? Well, I took this expression, of course, from the conceptual engineering literature. Conceptual engineering is the philosophical methodology that basically describes and prescribes also how to form and to build new concepts in light of objectives that can be epistemic, but also ethical, practical. Conceptual choice is, as I see it, the deliberate selection between concepts that are empirically adequate, so concepts that are, true to the evidence, but sometimes we need to choose between them, among them, the one that it suits best what? Well, the goal that we find most important. So it happens many times that there are different ways to define scientific phenomenon or thing, let's say, but and then the scientific community needs to make a choice about and then find out which is the best concept to adopt. And in medicine, goals may include diagnostic utility, meaning, well, what is easier and most useful and more practical when it comes to diagnosis. Inclusivity, sometimes we need a concept that takes the point of view of and the needs of more populations and more groups. Treatment equity could also be one of the forces of the goals, but also research standardization, because if we one of the goals, of course, of medicine is to arrive at general results that can be applied to very wide populations. So some amount of standardization is sometimes very important to have. So, for example, it would be great to have a specific concept of well-being for any population, any specific population for each specific population. But then if we want to compare different populations, then we need a concept that is like more standardized. So conceptual choice is not just about truth or whatever that is, or being adequate to the evidence, but it is sometimes, most of the times, about fitness for purpose. And this, to me, is a sign, one of the many signs that, or the fact that medicine and research in general, but is value laden. It's not just about mirroring reality. So concepts matter. Different concepts can have different consequences in action in life. So silly example, concept of flower we have the concept of the botanic classification, according to which, well, artichokes do count as flowers. They are flowers. But then, and then there's the everyday concept that we use when, for example, I might say, oh, I would like to have flowers for my birthday. But then if I receive artichokes for my birthday, well, I might be slightly disappointed, even though they are flowers according to the botanist concept. Whereas in the scenario where I am offered roses, I'm happy. So it's not that the botanist concept is not a good concept. The two concepts are appropriate or best for different aims, for different objectives, for different in different scenarios, and we might want to choose one of the two concepts and exclude the other if we think that, for example, choosing nice birthday presents is our most pressing concern. Okay, so concepts matter. The two, we don't need to, establish on general grounds which concept is the right concept of flower, but the most appropriate concept for our objective or aim is a question that we might raise. Okay, so that was my let's say introduction about why concepts matter and how concepts matter in medicine and in science. Of course, there are many details to be fixed. For example, what is a name or an objective for a concept? And there's a lot of literature in the conceptual engineering area about this, which I wouldn't touch today, but I know it's a big issue and I just mentioned it. So back to our case for today. The International Association for the Study of Pain needs to define pain. Why? Well, because pain needs to be measured. Pain is really important, is a really important component of, many clinical presentations of diseases. So we need pain for clinical criteria. Also, we need to measure and to establish whether pain is present or not in research inclusion. Let's say we need to have to study whether people with painful arthritis in their knees benefit from, swimming sessions, right? So we need to define who counts as having pain in their knees, okay? Also, pain is to measure pain is super important for two research outcomes. A very simple case would be, in order to test whether a painkiller, right, a treatment is effective for the well-being of, let's say, cancer patients, we may need to measure the pain or the reduction of pain. And also there's an ethical discourse and a practical discourse about who has real pain and which conditions deserve the name of pain, because pain is a medically treatable condition. And so if you have real pain, then you can be cured or treated by medicine. So there's no doubt, I would say, that it's important to define pain in medicine and to measure pain. Of course, it's also important to understand what pain is as a real phenomenon, but this doesn't exclude that we also need to define pain. And that's why the International Association for the Study of Pain has been, proposing definitions and also ways to measure pain. Okay, old definition. What is pain? An unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. from 79 to 2011, because from 2011 on, there was a huge discussion and let's say a huge process of change that that happened within the IASP that brought to a new definition. I don't know if you read this definition, maybe you already you can spot some weaknesses or some possible problems that this definition might have. So one thing that people said was, well, described in a potential an unpleasant and emotional experience described in terms of such damage. Well, someone said maybe described tends to, let's say, exclude people, pain reports from people who, or sorry, pain manifestations from people who can't describe. There are many people who can't describe. Small infants, very young infants, small children, or people with conditions of cognitive impairment, severe cognitive impairment, and so on and so forth. Of course, you are philosophers and you notice that the conjunction is or, so it is a disjunctive. So, I mean, the description is not needed in the definition. It's not a condition for having pain. But still, some people have been raising an eyebrow with respect to that description clause, right? Because it makes it too verbal. And also associated with actual or potential tissue damage gradually became an issue. So, and I will tell you why in a bit. So there was a long process of revision that ended about 2020, in about 2020, and then it was published in 21. So now the definition is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or resembling that associated with actual or potential tissue damage. So the big issue is about of adding the resembling clause. So now it's not just an experience associated with tissue damage, but also an experience resembling that associated with. And this is a very big thing. Why? Because in this way, we can, we can apply the concept of pain. We can categorize as pain also experiences for which there's no actual or potential tissue damage that is individuated by doctors with, let's say, imaging, lab issues, clinical inspection. So even also cases where there's no evidence, bodily evidence of pain, we can talk about having pain. Unpleasant. Well, unpleasant. People have been debating whether it is a good word or not. Maybe other words could be more like, let's say, phenomenologically rich than unpleasant. But still, the key issue is the switch from associated with to associated with and resembling that associated with. So this counts as a more specialized conceptual tool for the study and for the, the therapy, the treatment of pain. Why? Because first, it is more inclusive. It's, well, the description part was dropped. So infants, non-verbal patients, animals are in. Yes, there was the or clause, but still the description part was misleading. And also, and that's the main thing, chronic pain with no tissue damage. For example, pain that is characteristic of fibromyalgia, and other conditions like irritable bowel syndrome. These are conditions in which pain can exist and can be reported by people and can be felt by people, by patients, and doctors can't find any tissue damage, can't find any lesion. There's no biomedical marker of the cause of pain. So the ethical outcome is that this new definition legitimizes all pain reports, most pain reports, right? And that's why it is a deliberate, value-laden conceptual upgrade. So it's the choice of a concept that is more inclusive with respect to these patients and these people. It's very interesting because you can follow all the documents and all the, most part of this process of revision through the website of the IASP. This is, in fact, this is the consensus document that was published when the definition itself was published. But there's a lot of material on the website, and also a lot of educational material. So it's really a very rich area. It's interesting to see that also philosophers were involved in devising and in choosing the new concept of pain. Philosophers that have been somehow involved in the study of pain on philosophical grounds. For example, Murat Aydin, and also the bioethicist Singer, but also Adam Shriver and Nicholas Shee at Oxford. So philosophers were consulted first because of the described in terms of clause. And of course, I did immediately said, well, there's a nor disjunction, so you needed to really focus on the described in terms of, because it's a disjunctive clause. But then, okay, but they were important in saying, let's be as inclusive as we can, also with respect to people with respect to people and beings, also animals that can't describe in any way verbally. So they were involved firstly in that, and also not just philosophers were involved, of course, but patients and people of the broad community were involved. There was a public consultation. It was a web-based survey, and it went on for some months. So basically, you could just sign into the website and then post comments. And there were 8 questions about demographic questions, right? And so people could give their feedbacks. And at this stage, it was not, so it was free, not just patients or people with a condition, but also practitioners of various kinds of specialties. And of course, okay, the number was quite high of people who participated. Most of them were from Canada and North America, but still it is interesting. And some very useful comments from this consultation were accepted, and then they became part of the definition that was finally accepted. Sorry, I go back because unpleasant was the term, but the initial proposal was an adversive sensory and emotional experience. But of course, unpleasant is easier to understand. Okay, so to go back to the main issue, to the main change in this new concept of pain is we have pain that arises from altered nociception, despite no clear evidence of tissue damage causing activation of the receptors of pain, and no evidence of disease or lesion of the somatosensory system causing the pain. What does that mean? Pain comes from, well, lesions, or it might come from an alteration of the, let's say, the part of the nervous system that registers pain. But the new pain that now it is introduced is pain that doesn't come from any of these two sources. It's not nociceptive, so it's not about having a lesion, and it's not neuropathic. It's not about having an altered pain, an altered system for pain registration. Wow, so it's like it names the unnameable, and it targets precisely conditions like fibromyalgia, in irritable bowel syndrome, or also complex regional pain syndrome is another very mysterious syndrome that may affect people also after surgery. Why I also mention IBS, because some people with IBS report that even when they don't have the, they are not in the inflammation stage of the disease, they still have pain. And so pain is like something that lingers on after the inflammation is gone. So this change in the concept, this is the choice of a concept that is much more extensive. It has a larger extension, a different intention, yeah, but also a larger extension. And it reflects both scientific shift and advocacy-driven. And it is advocacy-driven. So to recap, pain can be typically nociceptive, means, okay, when you have an injury, arthritis, you know where the pain comes. Doctors know where the pain comes from. They can find it. It is like somewhere in your body. Neuropathic, again, here, it's slightly more difficult, but doctors can know where the pain comes from. Nerve lesion. Nociplastic is a new one. Well, it's something that cannot be located, at least now, medicine can be located where in the body is the origin of this pain. And sometimes it is also phenomenal. The experience of it is different because it's more like diffuse. It's not really localized. And people who experience chronic pain can describe this condition quite better. So it is a conceptual response to clinical gaps. And patient advocacy played a key role, and the International Association for the Study of Pain established, let's say, a group called GAPPA. And this group gathers people with pain conditions who are interested in collaborating with research and with the change of guidelines. So the new definition immediately had clinical consequences, because now reports of pain reports of people who don't have lesions can be taken at face value, right? And at the same time, 2019, the definition was already into the making, so it was like already sort of known. The ICD, which is the International Classification of Diseases, let's say, validated chronic pain as a real medical condition, which is absolutely key for many people. So it was a good conceptual change. It was a good decision made for many reasons, because it gave recognition and validation. It helped, recognize pain reports of population of patients that were previously not recognized. You know, pain that is in your head, or pain that is of psychological origin, or these are typical, you know, labels that were used to define and to silence and to marginalize pain reports with no biomedical marker. And so the burden of proving pain, or having one's pain proved, is somehow lifted and reduced. And it is definitely, you know, an inclusive kind of definition. Well, of course, it can be improved. Well, patients and groups said that, well, maybe the term nociplastic is not really good. And also, of course, a definition is not sufficient. A new definition is not sufficient. It needs also to be, you know, put into practice and operationalized and become part of clinical practice. And that comes only with training for providers and, you know, and rewriting of guidelines in specific areas. So of course it can be improved in this sense. Because now guidelines are, you know, recommendations of what to do that clinicians should follow. Most current guidelines are like very condition specific and very biomedical, and they focus on lesions and they focus on neuropathic mechanisms. So it's not really something that has you know, completely penetrated the community, but it's on its way, right? Okay, so to go back to the pros, is a case of a definition as recognition. And we might also use the epistemic injustice framework to say that many patients with chronic pain conditions were not taken seriously due to lack of visible cause at the individual level, so at the level of testimonial injustice, but also at the systemic level because of lack of a proper concept, not just a concept to express one's pain, but a medical concept to validate that expression of pain. And now this extended concept of pain covers this area, so it mitigates hermeneutical injustice. It still might be true that testimonial injustice occurs, because we know from the literature that, you know, these populations of patients or people are traditionally marginalized and sort of silenced and gaslighted by medical practitioners. Of course, not always, but there can be episodes. So, but still, nociplastic pain and this augmented and enlarged concept of pain can be an hermeneutical repair. So in this sense, the inclusion of lived experience has reshaped the ontology of pain. Okay. But there's a price to pay. So a good conceptual choice, but also a conceptual choice that came with some shortcomings. First is like a sort of conceptual tension within the pain terminology. Okay, because I introduced like surreptitiously this word nociception and nociceptors. What is this thing? Well, nociception is the neural process of encoding and processing, you know, painful stimuli or whatever. So nociception is the physiological mechanism that detects, that gives you the pain experience, right? That detects neural sign from actual or potential tissue damage and gives you the pain experience as an output. So is it a mechanism, right? And then there's pain, and pain is the name of an experience. And now we are told, well, now we're told that there's pain without nociception. So nociplastic pain is pain without clear nociception activation. So now we have, well, nociception is no longer the mechanism that produces pain, because there can be pain without nociception. So maybe there's also the need to redefine nociception, or to enlarge and to specify the concept of, or what is the model of nociception. That's what some commentators argued. So this new definition of pain sort of somehow breaks the very important link between pain and the mechanism that produce pain. So, well, it's a problem. There's a lot to do. The biology, the model, the mechanistic model of nociception needs to be investigated further, because as it is, it's not compatible with the new definition of pain. That's what they say, and I think it's a good critique. So it's not, so the definition of pain in itself is good, but then we need some work on the nociception side. Well, the main thing is that now we have some, pain with no pathophysiology, and it's a gap. It's a medical gap. So work needs to be done to discover what the mechanism is. And also, it might be said that plastic, because it's called nociplastic, plastic implies adaptation, and it need not be true that nociplastic pain is adaptive in any sense. The third risk is, I would say, more serious, because it has to do with pain management and care, and it's the risk of, let's say, premature closure, diagnostic closure. What does that mean? Well, now if I go to my family doctor and say I have pain, diffuse pain, it might be a chronic condition, and then I show the doctor that my exams and lab results are fine, then okay, the doctor might say, well, it's a case of chronic pain, it's a nociplastic kind of pain, and okay, that's all. So in one sense, it validates pain reports of unknown origin, but also it validates that the origin is unknown, and sometimes it would be better to try to find more, because sometimes there might be an occult neuropathy. So it might be that, we shouldn't give up on finding out. Clinicians shouldn't give up in finding out how these kinds of pain and conditions function. So, nociplastic pain shouldn't be taken as a diagnosis that, crystallizes the condition once and for all. So it is a tool that serves to, validate pain reports, but shouldn't be something that freezes the person's condition in, pain that can't have any mechanistic cause, right? So, and this is what, for example, this article claims. They say, well, maybe they mitigated, interpretive hermeneutical injustice in broadening the concept of pain and including nociplastic pain. But a problem that can still arise is another, we might say, epistemic vice, which is from the medical side, inquisitive inertia. So it's just nociplastic pain. That's nothing more to detect. So benefits and trade-offs, benefits and problems. Legitimizes under-recognized pain, supports patient-centered care, encourages multimodal treatment, challenges reductionism, but it also a vague diagnostic criteria. There's the risk of premature diagnostic closure. There's also the potential for overprescription. Why? Because I might go and say, well, I have pain, and now my pain report has to be, at least prima facie validated. Possible over-medicalization of conditions. This is a risk that might be, that could happen, that could take place. So, well, it's not really the case that pain can be faked, okay, on a long-term basis. People can be good actors, but these are really minor cases in which people fake pain. The problem is not that of faking pain or, delivering fake pain reports, but it's more like, extending the pain too much. And what is too much is really so difficult to fix and to indicate. And you all know that there's a problem with the opioid crisis in many countries. So people take a lot of pain medications when they are not needed, and which is specular to the other problem that people who need pain medications are not given those medications. So it's really a difficult ethical balance to be made. And at the moment, the decision was to broaden the category of pain and to risk that people take more medicines or medicines for a condition that don't really not really benefit so much by those medicines, but still it's good because it opens up the possibilities of care to more people. And also that people with fibromyalgia and chronic pain conditions were traditionally given antidepressants and sedatives. So now they might be given painkillers, which might be a risk, but not in all cases. So I rushed a little bit towards the end because time is running out, but I just wanted to show you that this case of the revision of the new concept of pain is fascinating, and it's full of very complicated matters. But to me, is also a typical case of conceptual choice in which, well, one concept, the broadened concept of pain, was chosen and was preferred to the other concept, the more restricted, on the basis, of course, of evidence, but also on the basis of values, on the basis of practical considerations, and also on the basis of consensus among stakeholders. So I think it might be said, this is a job for philosophers. Philosophers can interrogate the values that are embedded in conceptual change. They can clarify distinctions between overlapping concepts. And also they can assess the trade-offs between, inclusion, specificity, and also the other ethical dangers. And also they can defend the needs of marginalized patients when they are somehow not considered. So there's a lot of conceptual choice going on in medicine, and this is a case. And I think one role of philosophers in these areas, in philosophy of medicine, but also in philosophy of psychiatry and philosophy of psychology, we might, let's say, see ourselves as, conceptual gardeners, meaning that we may tend, prune, and occasionally uproot or seed new concepts that shape research and practice in medicine, psychology, and psychiatry, not just for purity, but also for justice when there are rights of people or groups to be defended. And I think it's a very important role, and sometimes it is kind of neglected because it's not frequent that philosophers really have a share and are consulted in these decisions. And I think this is all from me today. Thank you for listening.